Morning, sir. Mohan, sir.
Good afternoon, Sinu.
Morning, sir. ఎవరు మన గుడ్ మార్నింగ్ జడ్జారి సార్. చాలా రోజులు
ఏంటన్నా స్పెట్స్ పెట్టావు, ఇంతకుముందు ఉన్నాయా నీకు?
నాకు అప్పుడప్పుడు పెడుతుంటాను నేను. చిన్నవి కనిపించట్లేదు ఈ మధ్య, అంటే దగ్గరికి కనిపించట్లేదు.
దగ్గరే కనిపించలేదా? దూరంగా వెళ్ళి చూడు, మరి దూరంగా వెళ్ళి చూడన్నా.
అందుకనే దూరం వెళ్ళి చూస్తున్నాను. అన్ని టైంలలో దూరం వెళ్ళలేము కదా, అందుకనే సెక్స్ పెడుతున్నాను.
మ్యాండేటరీ అయిపోయింది. ఇంకా
ఏం సార్
మ్యాండేటరీ అయిపోయిందా? ప్రతిదాని దూరం వెళ్ళి చూడడానికి కష్టం కదా.
ఫైనల్ గా మోహన్ సార్ క్లబ్ లో చేరాల్సింది అందరూ అంటున్నాను.
ఏంట క్లబ్ అది?
అదే మోహన్ మహారాజ్ గారు స్పెట్స్ పెట్టుకుంటారు కదా, మనం అందరూ కూడా పెట్టుకోవాలి మరి.
అంతేనా?
అంతే కదా, వయసు పెరుగుతుంది కదా సార్.
అది క్లబ్ లో చేయాలని అసలు ఇంకేమైనా ఉందేమో స్పెషల్ అని. సార్ ఉన్నారా సార్?
సార్ ఉన్నారు సార్, ఉన్నారు.
ఏం రెస్పాండ్ అవ్వట్లేదు మరి?
ఏం లేదు డేవిడ్, ఎందుకు ఊరిని మాడుతారు కదా అని. అంతే,
మీరు రెస్పాండ్ అవ్వాలి కదా సార్. మీ క్లబ్ లో
గుడ్ మార్నింగ్.
గుడ్ మార్నింగ్ అన్న.
గుడ్ మార్నింగ్ సార్.
గుడ్ మార్నింగ్ సార్. సతీష్ సార్.
Sino sir, good morning. Shall we start?
Yeah, good morning all of you. Today, after 2 weeks of gap, Dr. Satish is going to talk on ICU airway management in ICU environment. It's a new topic, a boon and bane. So I request Dr. Satish to start the presentation. Anna, please go ahead.
Yeah. Good morning all. Slides are visible?
Yes.
Yeah. So today's my topic is management of airway and ICU environment, because we are all, most of the team members are anesthetists and we are very comfortable in intubating the patient in a very comfortable environment like OT atmosphere. But at the same time, as an intensive care specialist, we have to intubate in some unfavorable conditions and existing conditions like ER. And ward patient is getting cardiac arrest and we need to intubate their code blue management. So intubation in a non-acquainted environment or environment which is not under our control is a challenge. So I just want to discuss few things in this aspect. Scenario 1 is a 70 years old male patient. He has a restricted neck movement. His blood gases are showing type 2 respiratory failure, pH is 7.05. Oxygenation is good, more than 100. PO2, PCO2 is very bad, it is 98. Bicarbonate is 32. So this patient has slowly deteriorating in his alertness, is becoming drowsy. His GSS at that point of time is E1, V1 and M5. So it's almost like everybody agree that this patient requires airway management, either at initial trial of BiPAP or maybe we should get ready for intubation. This is one condition. Second scenario is a 56 years old female patient, tachypneic, more than 45 breath rate and tachycardia more than 140 per minute heart rate. Now BP is reasonably okay. Blood gas is showing severe metabolic acidosis with high increased anion gap and elevated lactates. So blood sugar is 980, probably looking like a diabetic ketoacidosis. To manage his internal environment and optimizing his, we need to plus or minus intubation is one condition where we consider intubation. I don't say he definitely requires intubation, but at this point of time, maybe if he deteriorates, we have to be in a very get ready for intubation. Third scenario is 64 years male, altered sensorium, right upper and lower limb weakness with power 0/5, labored breathing, aphasia, GCS is less than 8. So it's a CNS cause for intubation, airway protection. A 38 years female, hypotensive, less than 80/30, blood pressure, tachycardia, more than 120, tachypnea, blood gas, metabolic acidosis, elevated lactate, bicarb is low, pH is on the acidotic side, carbon dioxide is compensating, oxygenation is on the borderline, 64 is the PO2. So this is routinely we come across is almost like we can call it as a septic shock patient. So to decrease the oxygen consumption by diaphragm and all these things, this is an ideal candidate to get intubated. So these are the 4 different scenarios. All these patients are at one point of time in the coming due course in another half an hour or 1 hour, if they deteriorate, we should be get prepared and get ready for intubation technique. So having understood this scenario, just a little bit importance given to the historical aspect of airway management. Egyptians, particularly in the ages of Hippocrates writings, clearly told that there is an airway can be managed putting a hole in the neck. This is a basic thing, putting a hole in the neck. And Alexander himself has done this procedure in a patient who happened to be a soldier who got asphyxiated while he's having his food. So he deliberately opened the trachea of that soldier. Then coming to the George Washington, who died because of the peritonsillar abscess. So he's a candidate who actually wanted a opening at the front of the neck. Then in the historical paintings of Leonardo da Vinci, he clearly mentioned there is arteria aspera, which otherwise called as the trachea, is one of the source of danger when the patient get asphyxiated and patient may die because of there is some obstruction in this tube. Then a Danish anesthesiologist by John Ebsen saved the lives by performing tracheostomy. This is how the tracheostomy history has evolved. This is one ancient book, lectures upon the different organs in the body, heart, lungs, pericardium, and in this, on the right side of this, you can see that the trachea or aspera arteria is a tube canal extending from the base of the mouth to lungs. So this is how the trachea terminology came in and how it was called in the ancient times of the Greek literature. And different terminologies like bronchotomy, tracheotomy, and tracheostomy. So this is how it involved. Initially, they called it as bronchotomy. Then it was sometime it was called as tracheotomy. Then it came as, now we are calling it as tracheostomy. The first known depicted tracheostomy done in 3600 BC by Egyptians. Then later Alexander has performed it without having any specific principles. He just opened the trachea, I told you. Then the writings of Aratus and Galen. So he mentioned about this opening of the trachea in the 2nd century and 3rd century. And it is being performed by a Greek physician, Asclepius, about 100 BC. The time frame is 100 BC. The first scientific reliable description successful tracheostomy is in Antonia Musa Barsavola in 1546. In later 1718, Lawrence Heister, he described the term called as tracheostomy. And later, Jackson is the person who clearly described the procedure of a tracheostomy. So we all know that silver Jackson tube or metal tracheostomy tubes on his name. Then this has become vogue and it became very, very popular in the polio epidemic. Most of the patients being survived because of the tracheostomy in the polio epidemic. At present, tracheostomy is more done for patient who is in long-term mechanical ventilation to prevent the complications of having an endotracheal tube and the mucosal necrosis, and more so in the upper airway obstructions. So indications for intubation, we all know routinely it's our bread and butter. A patient is not breathing is a one definitive indication. And sometimes patient is breathing, but this breathing is not enough for adequate oxygenation or carbon dioxide. So next is patient is breathing enough, but hypoxemia and hypercarbia is not still getting corrected. Patient breathing with gas exchange is stable, but still his work of breathing is more. This is the 4th indication. The last indication is airway protection. So these are the 5 basic indications for airway protection, advanced airway management. How best we can perform this, whatever may be the procedure, how best we can do, how skilled we are do, still this emergency intubations leading to 2 to 4% of the cardiac arrest situations. And we all know that we are acquainted with one procedure in an unfavorable environment patient who is in demand for intubation. We all well versed with this rapid sequence intubation technique where we do a procedure like induction, intubation, everything is being very rapidly managed, and to prevent the aspiration, we usually go with Salix maneuver, we need to have a proper laryngoscope, and intubation technique is performed in that way. We all know, well known, that there is a procedure called as pre-oxygenation for 4 minutes, giving 100% oxygen to avoid the need of mask ventilation, which may cause an aspiration we don't know the stomach status of the patient. Maybe it is recently fed and there is a possibility of aspiration when do a positive pressure ventilation with a mask without protecting the airway. Then there is like high risk patients, like patients who are in the high risk, like full stomach patients, pregnant patients. These patients will have a high risk to have an aspiration. Then supraglottic airways came into the like last 20-25 years. We came across this LMAs and all those. So they facilitate these endotracheal intubations, and we can avoid certain times intubation for a short-term procedures, or we can tide over the primary cause, can be treated and manage it properly. Tracheal intubation in ICU, a life-saving or the life-threatening, is an article by our Diwatia and team from Tata Memorial Hospital, and it is being published in Indian Journal of Anesthesia, September and October edition 2011. They clearly mentioned what are the indications, how to do, how best we can perform, how best we can get a positive and best results preventing cardiac arrest situations in intubation, peri-intubation and post-intubation scenarios. Then airway challenges in critical care by Nolan. It's being published in Anesthesia 2011 journal. So coming to the concept of difficult airway interventions, critical ill patients are potentially very difficult. The reasons are basically the disease process is worsening. Why we are intubating this patient is this patient definitely requires good oxygenation and good carbon dioxide washout, or to decrease the work of breathing. This is the basic, the pathophysiology is ongoing. Still we have to intervene in between, and we are stopping breathing at one point of time, which might worsen this patient during that shorter period, however short it is. Then there is no preparatory time for such intubations. Normally we have that all 5 P's and the preparation time. So in these patients, we don't have a proper preparation time. Then comes hypoxemia is still worsening, and we cannot even increase the oxygenation despite the patient is already in low saturation. We might have already used NIV, we might have already used HFNC, then whatever we have done, still patient is hypoxemic. Then here the concept of pre-oxygenation does not exist. So normally what we do is we pre-oxygenate the patient to tide over the time of apnea while we are intubating and doing a laryngoscopy. But in these patients, we don't have the time, and we cannot have a process of pre-oxygenation in these patients. Then comes this patient is otherwise unstable, like patient BP is on the lower side, patient is on like high metabolic acidosis condition. So these patients are very vulnerable. A small change in the environment for a brief period itself causes cardiac arrest. And we discussed that risk of aspiration in such patient because it is a ill-prepared patient for intubation. Then maybe the patient facial contour is not good. That's the same thing what we come across in a difficult anatomical airway. The same applies here also, and added to that we have a problem. And challenges related to the location. We are not happy with the environment because we may not have a boozy, we may not be having a working properly working laryngoscope, we may not be having an adequate size of the laryngoscope blade. So this is the environment problem is there. We are not well versed to handle such situations in that particular environment. We are all happy to have such situations we can easily tackle in a established OT condition. Though there are 2 different situations here we discuss on: anatomical difficult airway and physiologically difficult airway. So the new terminology now we are introducing here is the physiological difficult airway. Recognition or deranged physiology in a patient is specifically very, very important in such patients. Anything that causes a change in the internal environment will definitely lead to the devastating effects. Then comes the physiological difficult airway is nothing but the patient hemodynamics, patient physiology, and those things are at stake. So I'm not bothered about, because anyway we know that all the techniques that to look into difficult anatomical airway, there are so many mnemonics are there, there are so many measurements are there. These things can anticipate a difficult anatomical airway, but we also consider the difficult physiological airway. Whatever may be the most skilled technique of laryngoscopy, and we are trying to avoid all the decompensation, still there is a possibility of these patients crash out. So successful intubation can happen because we are very well versed and we are skilled enough and we could intubate, but ultimately in such situations we might land up into patient is successfully intubated, but patient had a cardiac arrest immediately or after intubation. The airway assessment, I don't want to go into the details. It's an anatomical airway assessment. So most of us, we gone through our anesthesia studies. We all well versed with these measurements. So there are different situations like difficult mask or supraglottic airway ventilation. So
మర్చిపోయాను చాలా కాలం అయింది
సార్ నాకు రాదు సార్, నేను నిజంగా మర్చిపోయాను. అంటే ఇది
చెప్తే బెటర్ కదా అని, అంటే టైం ఉంటే
చదివేయాలి సార్, అంతే థియరీ కదా ఇది, ఈ డిస్టెన్స్ ఆ డిస్టెన్స్ ఇవన్నీ మనం మిల్లర్ అది చదివి వచ్చినట్లే కదా సార్ అంతాను.
ఓకే సార్, ఓకే సార్,
ఐఎమ్ సారీ సార్, నేను కూడా దీంట్లో ప్రిపేర్ అవ్వలేదు పెద్దగా. So it's all just to read and by heart, that's all. Difficult mask or supraglottic airway ventilation, inability of unassisted anesthesia clinician to maintain alveolar oxygen, because we are not able to maintain a airway management. Like simply we are very confident that we can manage this patient with a mask ventilation with 100% oxygen, but sometimes we cannot because patient may not be having a teeth, patient may not be having a proper occlusion of the both upper and lower jaw. So these are all the difficulties where we cannot even mask ventilate the patient. We can mask ventilate it's a life-saving situation. Even though we cannot intubate, we can maintain this patient with a bag mask ventilation. There's a very, very favorable condition. Sometimes this is also not possible. Difficult supraglottic airway placement, and I am trying to put an LMA. I am not able to because my skills are not good sometimes. So sometimes the LMA size is not good. So these are all the situations where we are not able to do or place a supraglottic airway. Difficult laryngoscopy. Every small opening of the mouth, interincisor distance is very less than 3 centimeters, and there is a temporomandibular joint ankylosis. These things like very difficult. I am not able to introduce my laryngoscope, but I am able to manage the patient with a mask ventilation. This is one situation we might come across. Then we could see that airway is good, mask ventilation is good, but still I am not able to introduce my endotracheal tube because of some pathology at the entry of the vocal cords. Maybe there is some obstruction, there is a mass lesion, there is something happening. I am not able to put my tube into the trachea, even though I can see the vocal cords. This is the difficult conditions we come across. Predictors of difficult mask ventilation, sir: old age, male gender, obesity, edentless patient, facial contour is not comfortable, Mallampati oropharyngeal grade is 3 to 4, mandibular protrusion, thyromental distance is very small, like very less, snoring, which indication obstructive sleep apnea, and abnormal neck anatomy, unable to extend the neck properly, or there is a flexion deformity. Predictors of difficult supraglottic airway, again the same list comes here. Then these are the predictors of difficult endotracheal intubation. Prior difficult intubation already established. Once we tried in long previously, some attempt for a surgery sake, we tried to do this patient, but we are not able to intubate. So it's a documented evidence that this patient has a difficult airway. Then interincisor distance is less than 4 centimeters. Thyromental distance is less than 6 centimeters. Sternomental distance is less than 12 centimeters. Head and neck extension less than 30 degrees from the neutral position. Mallampati oropharyngeal classification class 3 and class 4. Inadequate mandibular protrusions. Neck circumference is more than 40 centimeters. Lack of submental compliance, that is hard and non-compliant. So this is a difficult, like we cannot medal the trachea from externally on the surface markings. The Lemon criteria is a mnemonic where we have to look and identify what could be the difficulty, evaluate the patient with the 3-3-2 rule, and assess the Mallampati scoring, and identify the patient is having an obstruction airway because of the obesity, and just identify how best we can do the neck mobility. Is it the restricted mobility or not? So this is Mallampati class 1, 2, 3, and 4. Class 1, everything is easily visible. I can see the hard palate, I can see the soft palate. Uvula is significantly seen. Fascial pillars are very prominent. So there is clearly I can see all the structures. But if you go to the class 1 to class 4, nothing could be seen. Only the posterior aspect of the tongue is seen and hard palate is seen. uvula is not seen, fascial pillars are not seen, soft palate is not seen. And 3, 3 and 2 rule, like 3 fingers inter-insect distance, 3 fingers is submental space, and 2 fingers is the distance between the base of the mandible, like soft tissue to the Adam's apple. So that distance, 3, 3, 2 rule. Then a Roman mnemonic is a predictor of difficult bag mask ventilation. This is restricted movement, and there is a restricted head and neck movement and restriction to the lung compliance. Lung is not able to, we are not able to expand the lung with the bag mask ventilation. Patient is obese, patient is having an obstructive sleep apnea, mask seal, Mallampati, and a male patient. Average age is more than 55 years, and patient is not having a teeth. These are the conditions where we come across difficult bag mask ventilation. Assessment for difficult cricothyroidotomy. Basically it's a surgery, recent surgery. Some scar is happening on the neck because anatomy is distorted there. There is a mass lesion on the anterior aspect of the leg and access of the anatomy, particularly patient, obese patient, short neck, we are not able to do that. And patient who had a radiation exposure and some radiotherapy, there is a stiffening of the structures at the neck, and patient might have a tumor in the surgical area. Rods is one mnemonic, placement of the supraglottic airway, restricted lung or mouth opening, obstruction, distorted airway. All these things are mixed up, only the mnemonics are changing. Ultimately, there are 5 to 6 conditions where obstructive sleep apnea, decreased neck movements, decreased mouth oral cavity opening, and the patient is not having teeth. So all these things hold good for any of these difficult situation. This is the end of the anatomical descriptions. Now coming to the actual part of my talk, that is physiological difficult airway. Intubation procedure should include not only looking at the airway, we need to consider 3 aspects, like how are the hemodynamics of the patient, how is the gas exchange happening, is it adequate or not, then is what is the basic neurological condition of this patient. These 3 need to be considered before intubating a patient. Apart from also we are considering the anatomical aspects. The factors which have an effect are either patient factors, anatomical and physiological, pathological. Then the equipment, we may not be having a luxurious equipment to intubate the patient, and environment is not well versed to organize this intubation there. The timing, day versus night, midnight, daytime when all the team staff is available, midnight, untrained staff are there, environment is very difficult, poor light, all these things matters a lot. Medications availability, I want a hypotensive patient, I want to intubate this patient, I need to have either ketamine or etomidate, but pharmacy people can say that we don't have the etomidate at this point of time. The manpower, supporting staff, skills. So these are all the factors. Then the patient side, the disease factors are we intubating a patient for a type 1 respiratory failure? Are we intubating a patient for type 2 respiratory failure? If not, for a septic shock patient, the patient is having a metabolic acidosis, patient has a facial trauma, which there is a definite anatomical and physiological issues are happening, and patient has an anaphylactic shock and there is laryngeal edema. So these are the different pathological situations we come across for indications for intubation. Pre-oxygenation, as we all know, the pre-oxygenation increases the 4-fold. Like pre-oxygenation, if we not do that, there is a possibility all these intubations lead to cardiac arrest, because their existing disease is like that. Their environment is completely on the higher side. Any situation that stops their breathing, we give a vasodilatory drugs, already BP is on the lower side. All these things, ultimately, there is a possibility might lead to the cardiac arrest when the patient is not properly pre-oxygenated at least. So then coming to the second situation is the strategy of pre-oxygenation. We need to understand that we have to fill the increase the functional residual capacity with good oxygen. But thing is, the patient is in ARDS or pneumonia, he is still already struggling to have a good oxygenation. And despite giving good oxygen, good NIV support, good HFNC support, still the patient is not getting good oxygenation. Then where is the pre-oxygenation existence here? We may not get a pre-oxygenation properly in such patients. And we have tried all the procedures before intubating, and we are unable to achieve a good saturation, and the concept of pre-oxygenation does not hold good here. And NIV versus HFNC, yes, we can sometimes bring the oxygenation temporarily to the higher side before intubating. But patient who is being exhausted on NIV and HFNC, pre-oxygenation does not help us. Pre-oxygenation concept is to increase the oxygenation at the level of the functional residual capacity during the apnea period. This takes care of three things. One thing is a reservoir to draw upon the during apnea, that's FRC. And the maximum oxygen in that reservoir is denitrosation is happening there. Then the availability of that reservoir to resaturate the hemoglobin when there is a minimal shunt. The conventional high flow bag was ventilation for 4 minutes. It's like a normal physiology happens. It increases the PaO2 from 79 normal to 400 plus when the patient diffusion is reasonably okay. So all this is only where there is a problem, when there is a diffusion difficulty is there. When there is proper diffusion is happening at the alveolar basement membrane, so pre-oxygenation will push the oxygen content from the blood, that is PO2, partial pressure of the oxygen, from normal 60 to 90 to 400 plus. In a hypoxemic patient, it will not give the same result. It might push it up to a max of 90 mmHg. Patient without an airspace disease. So the pre-oxygenation usually accomplishes the first goal. FRC shunt are not usually concerned. Normally on our patients in ARDS patient, we have a lot of shunt fraction is happening. Diffusion difficulty is there. So pre-oxygenation is only we are giving a good oxygen up to the alveolar level. We are not sure that it is going to the arterial side because there is a thick alveolar basement membrane. There is a diffusion difficulty is happening, and which is the reason for the hypoxemia in such patients. Then more severe, a patient airspace disease, the hypoxemia like ARDS is one thing which we don't have a proper control, even we do a good pre-oxygenation in these patients. So this is how the oxygen drop happens in the apneic phase. An average adult patient with good alveolar basement membrane activity, he can sustain an apnea period of up to 8 to 10 minutes if properly pre-oxygenated for 4 minutes prior to the apnea phase. But it is not same for everybody. It differs with the patient. Patient with obesity, it is a different time curve. Pediatric patients with a different time curve. So ultimately, we need to understand an obese patient, we may not have that much time. In a children, we may not have that much time. An average adult patient who is having a weight of less than 70 kgs may sustain apnea period for a longer periods, say 7 minutes to 8 minutes, if properly pre-oxygenated and good oxygenation is maintained during the apnea period. Denitrosation. So higher the patient's workup breathing, and this is one point you need to consider, that if the patient breathing rate and tidal volumes, all these things will decide the FiO2. All we talk about the FiO2s in a static and like stable environment, who is breathing at 14 to 18 breaths per minute, who is drawing a tidal volume of 500 ml per breath, then all these things holds good. But my patient who is breathing at 30-35 rate, who is drawing a tidal volume of more than 800 ml to 1 liter, my FiO2 does not have any control. We assume that we are giving 6 liters, we assume that we are giving 10 liters, but it does not follow the same principles of that. If we put 6 liters in the nasal bronchs, it gives some 55%, 48%. Those things will not hold good in such environment. Please understand my point, that any patient who is tachypneic and who is drawing a lot of tidal volumes, FiO2 control is very, very difficult. We don't know how much FiO2 actually we are giving, even though our wall mount flow meter is showing 8 liters, 10 liters. Those things will not hold good in a open circuits and like mask and nasal pranks. I'm not talking about ventilatory support. I'm only talking about NIV, mask and nasal prongs. We only have a control over the FiO2 at the oxygen bobbin in the wall mount flow meter, which does not hold good in such patients, because the high flow will dilute the FiO2, whatever we are giving. We are giving only 6 liters of oxygen per minute. So that is 6 into 60 seconds, if you take it like that. So if you put a formula like flow is not sufficient, this flow is getting diluted with my original flow. My tidal volume is 1 liter and I am breathing at 40 per minute. So my flow requirement is more than 100 liters, but I am giving per minute, that is, and I am giving only 6 liters or 10 liters of oxygen from the oxygen bobbin in the wall mount flow meter. So this 6 liters is reasonably and highly diluted with the 100 liters of patient required flow. So this point you please understand. Then the procedure is we need to identify the patients, we need to stratify them. How severe is the hypoxemia? Is there any risk of desaturation during the apnea period? And factors that additionally potentiate the airway by any anatomical change. So we need to identify which patient we are actually dealing with. Then comes the, what is the PaO2 to FiO2 ratio? If it is more than 200 and patient is maintained with non-rebreathing mask, a flush rate, fast flush test at flush rate should be done in this patient. Like you have to proceed with a rapid sequence intubation. PaO2 to FiO2 ratio is less than 200 and more than 100. Use NIV or HFNC prior to intubation. PaO2 to FiO2 ratio is less than 100. Better do not knock out the patient. Do not create an apnea phase in this patient. Try to intubate this patient in awake manner. Awake intubation is described in such patients. This is what fast flush flow rate oxygen. This is, we need to give 50 to 80 liters of oxygen, a consistent flow through the non-breathing reservoir mask. So patient will breathe a oxygen-rich environment so that it might combat the hypoxemic phase of the patient when the patient is not breathing or not adequately breathing. The patient who is having high risk of desaturation, better to use HFNO or NIV prior to intubation. A most severely hypoxemic patient, we have to institute rapid sequence intubation, but pre-oxygenation with NIV is suggested. Most severe patients have intubation with HFNC. HFNO and NIV, particularly when indications are apneic oxygenation phase, HFNO will give a continuous flow of oxygen. So it maintains reasonably some additional oxygenation to this patient during this apneic phase. This is one technique called as transnasal humidified rapid insufflation ventilatory exchange, where high flow humidified oxygen via nasal cannula at the rate of 70 liters per minute is given. And it reduces the rate of carbon dioxide increase by gaseous mixing. That's, we used to do that transtracheal insufflations of oxygen. When the patient is already intubated, giving 100% FiO2, still there is some CO2 retention is there. There is a technique called as tracheal insufflation. Sorry, endotracheal tube tracheal insufflation, which creates admixture of the gases, and there is a established fact that carbon dioxide washout is better in such situations. Hemodynamics, pre-intubation hemodynamic compromise is associated with longer inpatient stay, increased duration of mechanical ventilation, increased need for renal replacement therapy, decreased likelihood of survival. So hemodynamics prior to intubation matters a lot, which have a negative impact in all these things. Cardiovascular collapse and leading to cardiac arrest is one of the commonest situations we come across when the patient has a poor hemodynamics prior to intubation. Shock index is one thing we need to look into. There are two different aspects. Like shock index is a crude thing where there is heart rate versus heart rate and systolic blood pressure is considered. So shock index is more than 0.8 is a negative predictor. And sometimes shock index is a crude thing. We need to go with the modified shock index. Modified shock index is heart rate. In the diastole, in the denominator, we don't consider systolic blood pressure here. We consider mean arterial pressure. So fluid resuscitation, we need to understand adequately fill the compartments when we are trying to give some vasodilatory medications. So this is, anyway, it comes into the ultrasound. I would see the IVC collapsibility. I can see the bilateral V lines. So these things, and adequately fill the compartments. 2D we need to perform, look at the LV contractility, how the LV is working. Then better to start or get ready with a vasopressor prior to intubation. Then do we go with the RV guided resuscitation? We are not well versed with that. Maybe it is one thing which help us in a patient who is hemodynamically unstable. Then comes physiological rationale for resuscitation prior to intubation. Yes, we have to keep in mind that fill all the compartments, identify the volume depletion patient, consider the vasodilatory drugs, what the deleterious effects of the vasodilatory inducing drugs, and when the positive pressure intubation, positive pressure itself will decrease the preload and decrease the blood pressure. In a spontaneously breathing patient, diaphragm displaces downwards, but in a patient who is paralyzed, diaphragm goes up and decreases the FRC. This need, and patient who is otherwise in a sitting position, for the sake of intubation, we make the patient flat and diaphragm will go towards the chest and there is decrease in the functional residual capacity. These are the basic things we need to understand, that how the internal physiology is changing because of our procedure. And we are stopping spontaneous breathing, that itself decreases the compliance of the lung. When the patient is not breathing spontaneously, automatically the compliance will come down. Once the compliance is coming down, I have to give more pressure to have a adequate tidal ventilation. So all these things we need to understand. Predictors of post-intubation cardiovascular collapse: all older patients, patients who are hypotensive prior to intubation, shock prior to intubation, intubation for respiratory failure who is having a impending hypoxemia and respiratory failure and high Apache score. Metabolic acidosis condition, patient is tachypneic, breathing, his breath rate is very high. For the compensation of the metabolic acidosis, lung is helping the patient, but we are creating an apnea in such patient for the facilitation of intubation. During that shorter period, his acidosis will get worsened. Successfully, we intubate the patient, but unfortunately, patient will have a cardiac arrest immediately after intubation. And need to understand that before intubation, take care of that priorly. Correct the acidosis before intubation if possible. Temporarily correct the acidosis. I'm telling that it's not acidosis, sorry. Correct the acidemia prior to intubation. Medications, we all know most of the inducing agents are venodilators. So there is no hemodynamically neutral medicine so far. Particularly, etomidate is considered as hemodynamically neutral medicine, but there is a consideration that it causes eternal suppression. Ketamine is an alternative, but ketamine may cause like spasm, and there is a difficulty in mouth opening in such patients if not properly relaxed. A muscle relaxant is not adequate. There is a problem with the catatonia, and patient will have a difficulty in opening the mouth. So this is the study. Propofol, ketamine, and etomidate, they're separately studied. They showed that compared to ketamine, etomidate and propofol are associated with better outcomes. These are all the different medications, starting from etomidate, propofol, ketamine, thiopentone, midazolam, dexmedetomidine. What are the neuromuscular blocking agents? Succinylcholine, rocuronium, adjuvants, lidocaine, and opioids. There is bundle approach is always better in our critical care. So there are three different concepts. That is pre-intubation, during intubation, and post-intubation. Pre-intubation, we need to have a standard 2 operators. Fluid should be preloaded, and preparation for long-term sedation. Pre-oxygenation for 3 minutes with NPPV may help and may not help in certain conditions. During intubation, rapid sequence intubation with etomidate and suxamethonium when there is no contraindication to have a suxamethonium, saying that hyperkalemia, severe acidosis, chronic neuromuscular blockade, these things we need to consider. Selix maneuver, and post-intubation, we need to take the patient onto a long-term adequate period of muscle relaxant, long-term sedation, and lung protective ventilation need to be instituted. Bundles, we need to understand that this is one publication, implementation of the clinical bundle to reduce the out-of-hospital pre-intubation hypoxemia. In this, they considered positioning of the patient, apneic oxygenation, delayed sequence intubation, and goal-directed pre-oxygenation associated with low rate of peri-intubation hypoxemia when compared to the standard out-of-the-hospital rapid sequence intubation. These are the guidelines published in, I think, Annals of Intensive Care. expert guidelines of intubation and extubation in the ICU patient, a French Society of Anesthesia and Intensive Care Medicine. This is for reference. And there is one concept called as Mocha score. We consider this, and ultimate total scoring is 12. Any score less than 3 is comfortable. So here they clearly given that less than 3 and more than 3, the Mocha score less than 3, we need to go with a rapid sequence intubation. So more than 3, we have to get ready with surgical airway management. So coming to our starting point. So now the environment, ICU environment for advanced airway management. So how do we consider whether it is a boon or bane? So consider that patient oxygenation is adequate or not. Is hemodynamics stable or unstable? Patient is a metabolic acidosis or in the respiratory acidosis. Are we forcibly doing this? Somebody is insisting us to intubate without proper preparation. Sometimes happens now, senior is there, he just forced the junior to intubate, man. Then that guy is not actually well versed or not comfortable, and he want to have more preparatory time. So somebody is forcing us to intubate this patient. Still we are not prepared yet. Is rapid sequence intubation a reasonable approach? If RSA is not reasonable, and awake intubation should be considered. Do we have sufficient time? Can I procure all the infrastructure and can I prepare myself? Can I have a help like second intensive care specialist who can help me in a better way? These things should be considered. So now it is an open discussion. Is it a boon or bane? The ICU environment for advanced airway management. Thank you.
Really correct, Srinivas. It's really not a boon.
Sir?
It is definitely not a boon.
Reason, sir? Support your statement, sir.
Yeah, I'm supporting. I don't know if I need to talk to first David. David, okay, na maadacha?
David లేడము.
అదేంటిది నన్నేమో లేడు ఇందాక అడిగాడు.
సరదాకి.
David sir. Sir, shall I speak?
Please, sir. చెప్పండి, sir.
So it's really nice that I didn't think this much time will be there, but you have been elaborated everything, and everything has been told regarding intubation time, using NIV, HFN mobile intubation, and difficult people using awake intubation. And David is a very fan of awake intubation. He doesn't want to relax until he gets the tube inside. And that's the reason I wanted David to be in the team actually discussion. And one important thing, what I have noticed with my, I don't say I have a very great experience, but I have a little experience. And with the recent, again, going into CPOT, learning PA catheters, again, relearning, not learning, relearning PA catheters with you in Satish in your institute.
Sir. Sir.
ఏంటి నిజమే కదా
సార్
నిజమే కదా మీ ఇన్స్టిట్యూట్ కి వచ్చి పిఏ క్యాథెటర్స్ మళ్ళీ రీలర్నింగ్ చేస్తున్నాం చాలా సంవత్సరాలు పాతది గుర్తించుకున్నాం
మా వాళ్ళంతా పాత టెక్నికల్ కాబట్టి మీరు చూసారు జూనియర్లు పంపించండి నేర్పుతాను
ఓకే ఇట్స్ నైస్ టాపిక్ actually when I was starting my career in anesthesia I think Mohan sir that's why he told my name that you don't paralyze the sedate the patient.
You prefer. There's a sentence there. There's a preference is different and from don't is different. If I'm using any sentence, sorry.
No. Because as he said, now he's telling the physiological difficulty, not anatomical, physiological. Those days I have seen so many physiological problems with intubation. Patient in shock, hypotensive, hypoxic, hypercarbic. And patient developed cardiac arrest after sedating and paralyzing the patient. Antega, sir?
Yes, sir. The main problem what I'm noticing is, David sir, I have seen all this arrest mainly because of anesthetist only. Because non-anesthesiologist will not have a much arrest. They have a less arrest because their approach is physiological. And as anesthesiologist, mainly we have been trained for anatomical, because whether we give per kg body weight loading dose or we give through the what you call 100 ml Buret and keep drug going. So that is our mistake of learning, because we don't do any unlearning. When you go back to the ICU and intubate in emergency department, you just see anytime, night time, any patient comes. Recently, one more patient has come, and because they have a sympathetic drive will be there for them to survive. So we are
Yes.
removing the sympathetic drive. So the patient is getting arrested, he will not come back. And if
Yeah.
you see recently, there was a study in KIMS and Yashoda, Hyderabad, they actually studied post-spinal also. Once the hypertension goes, they will not come back, they will die. So like that here, what I've noticed is around most of the patients, I don't say seniors or juniors, it doesn't matter senior or junior. There's something called aliquots. If you give, like for example, cardiac patient or neuro patient or respiratory patient, all three patients are different, including renal patient or pulmonary edema. So they will tolerate well. If the renal patient is getting intubated, he will tolerate well for intubation. He has a little more time in spite of UQ. But if you give the cardiac patient, what happens is, in the cardiac patient, you give the fixed dose as per the calculation, and he is going to die. Definitely is going to die. Normally, we are supposed to give only 20, because we don't have that much patience on intubation. We have to give only 25 micrograms per fentanyl, and we have to give only 0.5 mg metazolam, wait for 2 to 3 minutes and see the response and give next 0.5. That is what we don't do in emergency intubation, and that's what we don't do for an ICU. Unless we do that, because you, as Satish mentioned clearly, you keep doing a non-invasive ventilation or you keep using HFNO, then you have more time. It is not that we should do intubate, except for CPR condition emergency. We should not give a drug as per fixed dose. We should give only aliquots of 0.5 and 25 and keep giving. Understand the situation, because we think that patient is conscious, patient is having a blood pressure, patient is having a heart rate, and that will totally will go off. So that is what, and even neuro patients, what particularly the neuro and cardiac is really dangerous. Neuro patients, whenever we are given in unit 2, every time we used to have a patient will come with hypertension, and you give the loading full dose of propofol thing, the CPP will change, and that is going to change the outcome of the patients. So really, this is emotional for me. I really tell you. I have seen many patients dying, or they will be fine now, but after some time, because if it's a neuro patient, once you intubate, you think that you have intubated, you have done a good job. But yeah, please, Satish, sorry. Yeah, I'll stop.
No, please carry on. After that, I will talk.
So what I'm thinking and what I really wanted to tell from my side is that I have learned from burning my hands. So I really wanted every person, whoever is there in the team, never ever give a full dose of either sedation or analgesia, and never give relaxant unless you have a control over your airway and this one. These are the 3 points I would like to say. And as he was clearly told, keep everything ready. Never ever be overconfident. I can intubate this patient. As David said, it is not an anatomical problem. It is a physiological problem. So never ever have a overconfident. Every patient is a new patient. Every patient is a new challenge. So you should be that much serious about the intubation in ICU. It should not be taken light, because what happens now, most of the anesthesiologists, we can intubate any case. That's a mindset we have. So that is what I wanted to remove, that mindset, and say that every patient is new patient. We should not change the physiology. Like we are very much worried about vasopressor response in intubation. So we give more and more drugs in the OT. But whereas in ICU, it's other way around. So we have, even if we give 1 mg also, some old patient will just collapse there and then itself for many reasons, not only sepsis, hypovolemia, trauma, blood, anything, whatever, or as you said, acidemia, everything is dangerous, and drugs doesn't work properly when the severe acidosis is there. So that is the reason I would like to sincerely, because this is one of the important thing where it is in our control, where we can really make a change, and you can control the CPP. You should not, there's no vasopressor response here. There's only a physiological hypertension, arrest will happen. And particularly for respiratory patient and nephro patient, little better, because CO2 is blazing, not a problem. It gives some more time. And nephrology patient will not have much problem. He'll give some more time because the lungs and heart are good. So these two are important. Cardiac and neuro are very, very important for me in ICU. When they come in an emergency intubation, it should be very seriously considered, never given a loading dose, and only aliquots. Thank you very much. It's a really emotional topic for me. Thank you.
One question to Satish. Nowadays, we have a accommodate to maintain the hemodynamic stability in a unstable patient. Satish, what drug you are using for this patient in septic shock?
So, sorry, excuse me. So we go with intermediate if it is available, but sometimes it is not available. My style of intubation patient who is very unstable is I'll, as Mohan sir told, I'll give only small doses of the basic medicines. Whatever I have fentanyl with me, I have midazolam with me, I have suxamethonium. So give small doses, get ready with hemodynamic support like noradrenaline and everything. Start the infusions, fill the patient properly, hydrate the patient. Just as fast as possible, intubate this patient and continue your hemodynamic support. That's all.
What about retinal suppression in intermediate?
It is not proven. It was there in the textbooks, but still later on the recent literature says that it does not it's not a great problem. And just looking at that retinal suppression and avoiding intermediate has no rationale.
Because I am using only intermediate in the scoring for all
So now the
septic shock patients.
concept of causing retinal insufficiency, retinal suppression by using intermediate, previously it was hyped a lot, but nowadays nobody is bothered about that, and everybody using it left and right, and literature says it is very, very, very minimal problem.
Yeah. Any questions from Jekkana Srinivas, Mohan Rao, and M. Srinivas, Varalakshmi Rani, madam?
Sir, just I wanted to add some points.
Yeah.
Yeah. Sir, firstly, regarding just I wanted to contradict one of the Mohan sir's point that he has spoken. Just for the younger generations, there is a practice. There is a practice of not paralyzing a patient in ICU, which I feel to be maybe a wrongly practiced thing, because once previously it used to be a physiological difficulty. What you have mentioned, what all of you have mentioned is very right, but the practice of giving a full dose as compared to full dose as in ICU as compared to in OT has been changed since many years, because when I started my practice post MD, so there was no concept of giving a full dose of anesthesia for intubation in ICU. So the thought process has changed completely. So as of now, whoever may be the younger generation that are coming, so they are getting practice with small doses of anesthesia that's been going on. But paralyzing a patient in this scenario is being avoided in some case situations, is being intentionally avoided. So just what I wanted to say is, by avoiding the paralyzing agent, you are making your CL and grade one degree higher than the previous one. If it is 2, you are making it 3. If it is already 3, you are making it 4 by not paralyzing the patient. It's the already patient is having hypoxia and you are getting difficulty in intubation because the patient is awake. So obviously you are making the patient more hypoxic. You are making the perfusion more worse. So that has to be avoided. So if you see physiologically, you can give whatever the supports, you can make things ready with noradrenal, vasopressin, or adrenal, whatever you wanted to do. You can give some purges and you can maintain your BP, and then you can sedate with aliquots or a small amount of doses, which I have never faced a problem with the sedation, because I started by using a very lower amount of dose. And anesthesia obviously says, and in 3 years of training, what we have been said is the 1 mg per kg or 0.5 mg per kg is the sedation for a normal patient, and anesthesia is always based on the requirement of the patient and not completely on the weight of the patient or the age of the patient. So it is the requirement. If the patient is gets sedated with 25 or 30 mics of 40 mics of fentanyl and 1 ml or 2 ml of propofol, that's good enough for him. So obviously we don't need to give Second, use of suxamethonium and rocuronium gives your oxygenation, gives early paralysis, which can make the scene better in way of intubation. You don't need to wait for 3 minutes or 4 minutes, whatever necessary. So obviously, avoiding a paralyzing agent with if you are having all the supports makes the condition worse, or makes sometimes the person who is not well versed may avoid paralyzing agent and make the airway more traumatic and more bleeding, and he'll make lose the airway overall. So these things I have seen more rather than a difficult intubation. And what we have studied in anesthesia, that 4 to 6% is the difficult airway percentage, that out of all the 100% of intubations, and 96% of the intubations can be done because of the anatomical variations, whatever may be there. And out of the 4% of the difficult intubation, 2% can be avoided with your seniority and expertise and the slight minimal manipulations what you can do. So less than 2% will have a very severe anatomical difficulty in intubating. And as per the physiological effect, you are saying back up with everything what you need, with a good central axis, with a good vasopressor support, with mild sedation and paralyzing the patient. So you can make your intubation better, but it should not be taken lightly, as Mohan said. But avoiding paralyzing agent or has to be avoided.
One small correction. Who said to avoid the paralyzing agent?
There has been practice that is being going on, sir,
No,
in
please.
many places.
Never. That's what I told you. Never avoid relaxant at all. Never avoid. You take a control of physiology after sedation, give relaxant and intubate. Because if you give relaxant, your intubation success rate will be very high. I will never say that not to give relaxant. Maybe if I have said that, I'm sorry. I don't say that, because if you give relaxant, your intubation, relaxation, easy of intubation, everything is fine. Because the issue is that they're afraid of airway. Somebody may not give relaxant, but we always give relaxant, because that's the reason short-acting relaxation is available there with the rocuronium or suxamethonium.
Hello.
Madam, Chapandi.
Hello. Yeah. Mohan sir, Srinivas, yeah, I've been hearing both of you, and it all depends on individual basis, depending on patient hemodynamics and everything. So if somebody is bleeding, hemodynamically unstable, and you end up intubating quickly, and you don't have proper time to optimize before intubation, then I think unless you anticipate difficulty, you better avoid relaxant. Once we give relaxant, they just all sympathetic drive is gone, and they may just arrest as soon as you intubate. So it all depends on how the patient is, what the physiology is, and where you really need to give, you give. I'm not saying not to give, but it all depends on patient condition. That's what I want to say.
Madam, one small correction. You said if you anticipate difficulty, don't give relaxant is not good sentence, madam. Because
no, if you anticipate difficulty, you give. Unless you anticipate, I said. Not if you anticipate.
And no, one more thing. You mean to say unless you anticipate difficulty, you give, otherwise don't give. That's what you want to say?
Madam said if you anticipate difficulty, then give relaxant.
Give, otherwise you will make it more difficult.
No,
Short acting one, yeah, that's
Madam,
what I said.
Anticipate difficulty, if already you know that it is difficult, how can you give?
Anticipate difficulty, you should give relaxant is a point, madam. But only thing is, if you are worried about giving relaxant, you are losing a sympathetic drive, then that's different issue. Whether for intubation, giving relaxant is a good, always.
Sir,
Yeah, sir, that's why I said depending on patient condition, you decide. When somebody is with the patient, following the patient, they know the best what to do, not suddenly going and intubating.
Madam, if you anticipate difficulty, what you are feeling that it made more difficulty if you don't paralyze.
Yeah,
but,
exactly.
Yeah, exactly. Yeah, what I mean. But if you, after giving the paralyzing, if you are unable to intubate, then a situation like difficult intubation, difficult ventilation arises, and then may you lose the patient.
No, that's why I said you have to know the patient properly, like what's
That's
best
what.
for the patient. That's
May
what
not
I
be
mean to
fit for
say.
all the patients, all the.
If you are already on NIV, able to ventilate, if they're on HFNO, like maintaining okay, or bag mask, if you're doing able to ventilate, then
Yeah,
no
yeah.
problem.
Then-
Give relaxant.
Yeah, then all these things we have to do, just like that intubation, trying after relaxant may cause all the problems.
Yeah.
Yes, madam. And as you said, it's all depends on what type of patient you are intubating. Your patient is very critically ill and is severe hemodynamically unstable, and that time you sedate or paralyze the patient is depends on what type of patient you are intubating. It is our individual decision, not like that every patient need a paralyzing agent or all these things. Ante kada Srinivas?
Most of the patients need paralysis. That's what I believe, sir. That's my opinion.
Most of the patients may need, but not all the patients. Yeah, depends on the person is intubating, what type of patient you are intubating, all these things matters.
Maybe you will lose the sympathetic rate, obviously, even after
That's what,
intubation or
Srinivas.
before the intubation.
Yeah,
Yes.
that's what.
You may lose the
But not
sympathetic.
everybody. It depends on
Yes.
patient. You make the physiological environment better for intubation first.
I have a lot of recent experiences also with losing the sympathetic drives.
Adhe sir.
Sir, if you are ready with your vasopressor support, so and you are giving it, and you are as you are giving in aliquots, you just give a purge of vasopressors that you are providing, so you can control your environment in a better way. That's what I'm saying.
Srinivas, that's what I'm saying. If you don't have time to do all that, you end up intubating, then you have to be very cautious. That's what I'm saying.
Yes. True, ma'am.
In that
True,
time,
true.
just I will intubate, madam, without giving anything, because that that patient is crashing and already is drowsy, is not able to even fight anymore. Just to intubate, and then immediately you give some aliquots. What is there? Anything?
Mohan Rao sir wants to talk.
Mohan Rao sir?
Hello, sir.
Sir, చెప్పండి.
Excellent presentation, sir. Excellent discussion. Both Mohan Maharaj and Satish and Srinivas. And most of the time, I used to tell our people to give relaxant and intubate. If you are suspecting difficult intubation, give mild sedation, do the laryngoscope, and assess the airway, sir. That's all, sir.
New point here. So you mean to say that instead of only lemon criteria, you just give sedation, assess the airway, then plan. Okay, I got it.
But I'm in favor of giving a relaxant, sir, most of the time.
I am also Monroe.
Yes. Srinivas, I also came across.
Yes, Srinivas sir, మీరు
జై శ్రీనివాస ఇంటిబేట్ చేస్తున్నాడా?
కనబడలేదు.
ప్రాక్టికల్ గా చూస్తాడు.
So
okay, if there are no questions, we will close the session.
juniors,
Thanks, Anna.
juniors,
Thank you, Satish.
thank you, sir.
Juniors ఎవరు మాట్లాడలేదు.
I
I don't think they are facing any problems.
Harita from Secunderabad Apollo can share her experience recently. Harita? No, I think.
Yes, sir.
చెప్పమ్మా నీ ఎక్స్పీరియన్సెస్ చెప్పు, షేర్ చేసుకుందాం.
Same, sir. Difficult intubation.
ఏం చేస్తావు చెప్పు.
ICU patient.
Basically,
Because
you are a
sir, I'm
pulmonologist.
Dr. Harita, sir, pulmonologist and the ID system working as intensive along with Dr. Satish, sir.
చెప్పమ్మా.
Sir, అంటే paralyzing agent ఇవ్వాలి అంటున్నారు, but even after sedation, obese patient, actually it's a case of IC bleed. because of poor GCS, we have to intubate. OSA component undi, and he's also having obese, difficult airway anticipate chesamu. But still, without giving relaxant, I was unable to intubate because minimal airway opening anta undi. Patient even after giving low dose fentanyl mid as low dose ga escalate cheskunta velna, I was unable to intubate. Even if just relaxant ichina ventane, patient went into cardiac arrest.
That's what you are not prepared the patient fully physiologically before intubation. What do you say?
It's not physiological. It's not physiological. Physiological is reasonably stable, but the thing is, anatomical difficulty not properly identified prior to giving these medicines.
Okay.
So difficult happened because of the anatomical problem, not the physiological problem here. As per today's concept is physiological, but just to share and we have to accept our negatives. Openly, we are telling that we have done a mistake. Okay, we took it granted that we can intubate this patient, just like that normal intubation planned. But unfortunately, once the laryngoscopy process started, we found that this patient is having a difficult intubation and laryngoscopy, and ultimately we could not do that. We have tried the NIV and everything, we could able to ventilate, but later on we lost the patient. Intubation process was failure.
Okay,
But
that's the reason for, yeah.
we did not lose the patient.
చాలా కన్ఫ్యూజన్ ఉన్నాయి.
ఏదండి?
మా దగ్గర వన్ పేషెంట్ ఇరిటబిలిటీ ఉంటే పొరపాటు రిలాక్సెంట్ ఇచ్చి చచ్చిపోయాడు.
ఇందాక మీకు ఆపాను కదా నేను. My intention is, see, common situation is patient is having septic shock. Patient is having septic shock, and you are logically you are correct because lactate is going up, and that is one of the indication to intubate the patient and do dual vasopressor support. Patient family are talking to the patient, and if you say that I want to intubate this patient, and after intubation patient BP crashed and patient died, it is justification is very difficult to the family. Is it not?
Yes, I understand, sir.
My process of intubation only made this patient today because hemodynamically unstable, is having dual vasopressors and lactate is very high. I know that internal environment medically, because I'm a qualified guy, I know what is happening inside. But patient family and the rest of the people who are observing that patient, like my hospital executives, my sisters, my ICU, others, non-medical staff, those.
Don't record all these things. Don't record all.
No. They say that doctors have intubated and then patient, because of his intubation only patient died.
Yeah. Any procedure, any surgery, any procedure, they contribute to that.
Because it is not perceived. Elevated lactate is only finding. It is not seen by any attender or anybody saying that lactate elevated the indication of intubation. And at that point of time, after intubation, patient BP crashed and patient died, cardiac arrest. It is very, very tough situation to handle socially. That's what.
But if you don't intubate this type of patient, when patient in septic shock to inotropic support, if you don't intubate, by the time patient evening, patient
Sir David,
you cannot say.
David, here we are not think like sometimes now we have to think like a non-doctor. Patient died, arrested, intubated, that is different. Patient intubated and died, that is different thing. Please understand. See,
the situation is not that easy.
Scientifically, you are correct. Socially, you will be blamed. Scientifically, you are correct.
You have to. That's what has to balance.
Yes. Just
to play the game.
I could not intubate the patient recently. One patient, I could not intubate that patient. I tried many times, like 3 to 4 times. Then I used LMA, kept an LMA after even giving relaxant. I maintained that patient for LMA for 24 hours because patient family were not willing for tracheostomy. Difficult airway, not able to see the vocal cords, Mallampati grade 4. So I called the family and I told that this is a difficult intubation, airway protection because it's having a large hemispherical bleed. The GCS was poor, neurological patient. Family were not accepting for intubation. So we maintained that patient an LMA for 24 hours with sedation and relaxant. Next day they accepted and we had done tracheostomy.
So this patient may crash no at any time.
May crash because family are not willing. for intubation, for tracheostomy.
Yes. So all the times.
మంత్లో ఏదో మెసేజ్ పెట్టింది డేవిడ్, మంత్లో
Told us.
మెసేజ్ పెట్టింది.
మెసేజ్ మాట్లాడొచ్చు కదా.
I'm just reading. For intubation in ICU, consider patients as ACA grade 3 and 4 and emergency, and the drugs are given in graded doses. So message
well
which
taken.
suggestions is given. Yes.
Well taken.
Yeah. So if there are no questions.
Thank you.
Thank you, Satish.
Thank you, sir.
Thank you for all for your participation.